Hi, my name is Hans Lee. I'm a myeloma physician from MD Anderson Cancer Center in Houston, Texas. And today I'm going to be talking about the LINKER-MM1 study with Linvoseltamab in relapsed refractory multiple myeloma. So Linvoseltamab is in a class of drug called a BCMA bispecific T-cell antibody, or basically one arm of the antibody binds to a myeloma cell, and the other arm of the antibody binds to a T cell or immune cell and brings the T cell and myeloma cell in close proximity and leads to hopefully a lot of myeloma cell killing. And so linvoseltamab has shown encouraging efficacy and safety in earlier results presented regarding the drug. And so the phase 2 part of the LINKER-MM1 study is evaluating two different doses of linvoseltamab at either 50 milligrams or 200 milligrams to optimize the dose selection. So at this year's ASCO and EHA meeting, we are presenting for the very first time the initial results of the fully enrolled phase 2 part of the study at both the 50 milligram and 200 milligram cohorts. So patients who were enrolled on this study had heavily resistant or refractory multiple myeloma, had at least 3 prior lines of therapy, including PRISM inhibitors, immunomodulatory drugs, or anti-CD38 monoclonal antibodies, or they had myeloma that was refractory to all 3 classes of drugs, regardless of lines of prior therapy. And patients who enrolled on study then received linvoseltamab intravenously, initially with 2 small step-up doses of 5 milligrams and 25 milligrams dosed 1 week apart, with a 24-hour hospitalization after each of the step-up dosing. And this was basically done to mitigate the risk of something called cytokine release syndrome, which is a potential side effect of the bispecific T-cell antibodies. And then subsequently, patients received either 50 milligrams or 200 milligrams of linvoseltamab weekly for the first 3 cycles, which was then de-escalated to every other week for cycles 4 and 5. And patients enrolled on the 200 milligram cohort could then undergo further de-escalation in a response adaptive approach to every 4-week dosing if attaining something called a very good partial response or better. And so patients who enrolled on the phase 2 part of the LINKER-MM1 study had many prior treatments for their multiple myeloma. Specifically on the 200 milligram dose cohort, patients had a median of 5 prior lines of therapy. Approximately 3/4 of patients were triple class refractory, meaning that they're refractory or they had myeloma that was refractory to PRISM inhibitors, immunomodulatory drugs, and anti-CD38 monoclonal antibodies. And 36% of patients in the 200 milligram cohort also had high-risk FISH or high-risk cytogenetics. And 27% of patients were over the age of 75 years of age. And so the results demonstrated that the overall response at the 50 milligram dose cohort was 50%. And at the recommended 200 milligram dose cohort, the overall response rate was 71%, with 59% of patients attaining a very good partial response or better, and 30% of patients attaining a complete response or better on the study. And the responses seem durable, and so responses seem to deepen and over time as patients continue on therapy. And the 6-month probability of maintaining a response in patients who initially responded to therapy was 84%. And the median progression-free survival, which is basically the amount of time that the myeloma remains under control, had not been reached at a median follow-up of 5.6 months in the 200 milligram cohort. And the 6-month probability of progression-free survival was 73% on the study. In terms of side effects, the most common side effect of linvoseltamab on the LINKER-MM1 study was something called cytokine release syndrome, which is basically when the immune system activates and potentially can cause symptoms like fever and more severe cases, low blood pressure or low oxygen levels requiring supplemental oxygen. And so we were encouraged that the rates of CRS were generally relatively low. So 45% of patients had cytokine release syndrome who were dosed on the 200 milligram cohort. The majority were what we call grade 1 severity, which is the lowest severity, which typically manifests as a fever, which occurred in 35% of patients. And 9% of patients on the study had what we call grade 2 CRS. And so we're very encouraged and very excited about the results of the LINKER-MM1 study. It does demonstrate that linvoseltamab has high efficacy. and with deep and durable responses in patients who were dosed with linvoseltamab on the LINKER-MM1 study. And importantly, it also showed high responses in key high-risk subgroups of patients, including patients with high-risk multiple myeloma and patients with high baseline disease burden. And so, linvoseltamab, we think, will represent a promising approach among BCMA-targeted therapies. I think some of the things that potentially are particularly encouraging of linvoseltamab include the fact that the CRS rates are relatively low, or cytokine release syndrome rates are relatively low. And there's very overall limited hospitalization required to administer linvoseltamab, as it only requires a 24-hour hospitalization after each of the initial first 2 step-up doses. Infections in general have been a particular adverse event of special interest among bispecific antibodies in general. Overall, the rates of infection were similar between the 50 milligram, 200 milligram cohorts of linvoseltamab. Approximately 60% of patients experienced infections when dosed with linvoseltamab. About 35% of patients had more severe infections, we term grade 3 or grade 4 infections. And opportunistic infections were more rare atypical infections, occurred in 2% of patients dosed in the 50 milligram cohort and 8% of patients dosed in the 200 milligram cohort. So infection management is really, really important when considering the use of bispecific T-cell antibodies in general. And there's several key important steps. So one is infection screening and infection prophylaxis. And so it's important to screen for potential common pathogens that may be relevant when a patient's being treated with bispecific antibodies in general. Things like CMV, hepatitis B, hepatitis C. Once starting treatments with a bispecific antibody, then we would consider varicella zoster prophylaxis with either acyclovir or valacyclovir, as well as PGP pneumonia prophylaxis with Bactrim most commonly. In addition, vaccination is also important as well in patients receiving bispecific antibodies and myeloma therapy in general. And so staying up to date on flu vaccine, pneumonia vaccine, and COVID-19 vaccines are also important mitigation strategies. And finally, we also note that hypogammaglobulinemia, which is basically having a low IgG level or normal antibody levels in the body to help fight infections, is common with the bispecific antibodies. And so we often would administer something called IVIG, or intravenous immunoglobulin, to help support the immune system. Thank you for listening.